When you talk about a young diabetes and how you use a calcium score or a CT coronary angiogram, basically the way I look at it, it doesn't really differ greatly. The most important aspect here is you can screen diabetics early because their risk is higher, as we always learn, and probably the inference you get in terms of the risk conferred on the younger diabetics is much higher than what you would get with a non-diabetic. Let me start with this. I'm going to also share with you some very new information on new slides from the ESC 2021. So I was doing this moderation yesterday night for the CT part of it as well as heart failure. A lot of new information has come, and here is something which we need to quickly do. You see, we check the biochemistry and the lipid profiles, and then we heighten the risk, and then we accordingly medicate a patient. The time has come now to get on to the concept of a negative risk factor. So you scan a patient for the CT coronary calcium score, know what risk they have, and based on the risk, probably you have an hourglass pattern in which you may want to reduce some of the medications or not put them on unnecessary new medications. So here is the coronary calcium, which are the calcium hydroxyapatite crystals, and looking at their Hounsfield units, you look at them in the arterial zones and make a prediction. Calcium basically is bad news for a patient, as straightforward as that. And this is a very beautiful slide which came up yesterday. And it's a publication of more than 22,000 patients, long-term cause-specific mortality among young adults. So what is the prevalence? Then if you look at those two graphs on the left and right, and I can make that very simple, the dark bars is the younger ones. The dark bars is the younger ones. So if you look at calcium score prevalence, it's close to 80% in the younger patients. A calcium score more than 100 would be much lesser, probably the tune of about 1 or 2%. Then you look at the CHD, CVD, and age-cause mortality in the young. So that's predicted in terms of CHD, CVD, and the scores of 0 to 100 and more than 100. So if you look at age of 30 to 39 years and look at the events they get, the mortality they encounter, the lighter bars are the calcium score more than 100. The darker bars is a calcium score less than 0. Now, that's very crucial. So when you look at the calcium bars of 0 score and the risk, you clearly see that the CVD risk is still something, maybe 3%. So this is not great news. Now, if you go from 10 to 100, 1 to 100, the bar goes up immediately. This stresses the importance of investigating by calcium score patients early. Now, what's new in terms of was presented yesterday, that in patients of calcium score of 0, it's reasonable to repeat a calcium at the following intervals. If you have a low risk, 5 to 7 years, a borderline, 3 to 5 years, a higher risk, less than 3 years. So accordingly, you can make your judgments. That eventually means that if you have a diabetic, even if he's young, and if the calcium score is not 0, you may want to check it out after 3 years. Otherwise, probably even 5 years is good enough. And if you get these sort of calcium information, and let's say the calcium score is higher, we probably, as I showed in the first slide, need to change our paradigm and look at whether we utilize calcium as a predictor or a proof of atherosclerosis. Now, considering that the major events are pretty higher, stress test needs to probably go down in terms of just evaluating it right and left and doing it in health checkups. It adds nothing, because treadmill stress test, basic exercise test, will detect the functional consequences of atherosclerosis. It's not a proof of atherosclerosis. Myocardial ischemia can be because of a variety of reasons, cannot detect non-flow limiting plaques. However, if you get a higher calcium score, as I showed in this patient, then probably, let's say if it's more than 300 or 400, they will stand a chance of a higher positive stress test, and probably then a nuclear scan or a physiological information should be absolutely great. So turn the other way around. Use the calcium to know where you do a stress test. Once you do a stress test, you can heighten the risk and figure it out. Now, what happens for those patients on statins? The calcium will get hardened up. The risk prediction is absolutely similar in those patients not on statin and on statin therapy. It just makes the same prediction, right? So if you look at non-statin versus statin, prediction of CHD mortality is 2.3 and 2.5 as you look down, and CVD mortality is 1.8 and 1.9. No statin, on statin. What does this beautiful chart from Atherosclerosis Journal shows is that it doesn't matter whether on statin or non-statin is going to give you the same information. Way back, maybe about 14 years back, we also tried to look at the young and the diabetics. If you do not see any calcium at all, can you still have a soft plaque? Yes. Those were the very early days of CT coronary calcium score when we wrote this paper and presented it. Now, even if you have score more than 1 to 10, it tells you may still have significant lesions in 4.7% of these patients. For a diabetic, equally true for a non-diabetic, but for a diabetic is so very important. Look at the 4 cath lab features on IVUS that can be realized on cardiac CTA. The plaque characteristics, you see a remodeling of the vessel. In A, you see the longer short bars showing the remodeling. 2, the eccentric soft lesions. 3, the spotty calcification exceeding 3 millimeters. Right in C, where the arrow is. And 4, of course, is the classical napkin ring sign. Now, if you want to separate a young diabetic and a non-diabetic, in a non-diabetic, the presence of all the 4 or more than one of these features will be more predictive. But if you have a diabetic, then even one of them will stand true for a good predictable power for a vulnerable plaque. Just a final example before I close. Young diabetic, look at his LAD. Looks like a plaque in the LAD, apparently. And on cath, when we did it, there was a complete cutoff, and you can already see the nipple budding in the proximal LAD. And from what it looked like, if you look at the shadow, it looks like he already has a thrombus there. We went back, looked at the Hounsfield units of this plaque. It was about close to 40, and this was a thrombus. This was a thrombus in the LAD. This is a diabetic. So this is how you utilize this technique for prediction of a thrombus, which is quite common in diabetics. The plaque reporting will have to be on the communication based on this 4. Presence of coronary plaque, calcified, non-calcified, and partially calcified. CAD-RADS, the severity of stenosis, the calcium score, the calcified plaque burden, total plaque volume, and the low CT attenuation plaque. This is very important, that when you see a diabetic on a cardiac CT, please do inform this: the presence, the severity, the calcified plaque burden, and the semi-quantitative patterns. And finally, calcium score is a measure of plaque burden. It's guideline endorsed, in my feeling, ready for prime time. Let me tell you what my difficulty is. I am not a radiologist. And it's just my fortunate interest that I got into this science long back, and I've been continuing to work on this. And I've blended it with my other interests in heart failure and atherosclerosis and my clinical practice. And unlike a lot of cardiologists, I'm very convinced that cardiac CT has a future in terms of downgrading a risk and upgrading a risk, not just for statins, for all preventive therapy. The 6 places where you might want to discuss later in this session: young patients, low risk family history, repeat coronary calcium score testing when it is 0. When do you want to do it? on statins for sure, family hypercholesteremia, please. You may want to even scan 16s and 18s and 20 years old children, young adults, with minimize radiation and then get it done. And lastly, always look at all chest CTs, irrespective. Even if they are non-gated, you're going to pick up the calcium when you're doing it for all other purposes, like COVID in these days. So I always make it a point, asking the department to send me the COVID CT running videos so that you also look for whether there is calcium plaques in the coronary vessels. Let me thank Dr. Mohapatra, and I am going to ask your pardon because I have to log in and get on with the ESC sessions today. I have abstracts also for ESC on beta blockers in heart. Thank you very much for the patience hearing. Thank you.